I can't see everybody when I'm sharing my screen. So what worked last week in this class is when I ask you these questions, if you would utilize the chat, it historically last week showed me, or if you want to verbalize the start of the answer, that would be lovely. I don't care as long as we're all not talking at the same time, because that fouls up anybody's recordings. It kind of jumbles it. So that's what I'm going to start. I don't care. I'm going to pose a series of questions related to this Q theory article. I would like for somebody, just not the same person every time, mind you, but I would like us to have a discussion about this article because it has everything to do with a patient with a traumatic brain injury. And in case I didn't introduce myself to you, I apologize. I jumped right into it. My name is Cherie Wiggins, and I am going to be teaching you traumatic brain injuries today. All right, so the first series of questions we have related to this is, if you have that article handy, which hopefully you did, and hopefully you read. It's a short read. It is a recent document, so I'm not giving you information that's 20 years old. I'm giving you current. That read this, and you need to understand what we're talking about when we talk about cues, and it has everything to do with what you're going to do for a patient with a traumatic brain injury and the timing of it. Timing for interventions in nursing is everything. Just like the right time to intervene in any discussion, timing is everything. But you have to understand what cues you're seeing to lead you to understand when it's time to chime in and when it's time to back off from doing an intervention. Okay? So, the first question, would anybody like to, and I swear this is straight out of your article, would anybody like to tell me the difference between a ABI, which is an acquired brain injury, versus a secondary brain injury? You may speak.
Yeah, the ABI is a ischemia hemorrhage, and the secondary brain injury is an injury that had where the patient had like a change in mental status or cognitive status.
Okay, all right then. So, right, according to the initial, if the article further discusses the difference between an acute brain injury and a secondary brain injury, but it's basically the acute brain injury is the initial insult. We're talking specifically about trauma, bop upside the head type trauma, not the trauma of a stroke. Okay. So we're going to be, and I'm not even worried about, you need to understand the mechanisms of injuries for some of these things, but I'm not going to harp on the mechanism of injury because this is not a course in trauma. Trauma is my forte, but I'm not here to discuss that today. I'm here to discuss the chain of events that occur once that primary injury happens, because we can't control how the initial injury, we can't control the falls, we can't control the blunt force trauma, the car wrecks and all of that stuff. What we control is hoping that a secondary brain injury doesn't occur because of the primary injury. So hopefully that makes sense to everybody. So what is the cardinal sign of a worsening of a brain injury? And you don't need the article to know that. It's just that simple.
Change in level of consciousness.
Change in level of consciousness. My students, section 301 is in this class. They know that a HARP, we are on a stroke unit at East Jefferson. I harp on them. Get in there, get your baseline assessment on your patient immediately after report, because you need to gain a baseline assessment so that during the day when you go into that patient's room and talk to them, if they're verbal or if they're not verbal, look at those other those cues that they're exhibiting to know whether or not they're digressing or they're progressing or they're maintaining their status. Okay. So what is a cue?
Grimacing or agitation, anything.
And what, Nicole, what's another word for a cue that we use all the time? Cue is just another word for what?
Signs and symptoms.
Yeah. I was thinking about an aura, like before a seizure.
No. In a more plain version.
An assessment finding.
Signs and symptom, an assessment finding. Yeah, sure. And now they're just changing the verbiage, y'all, because the new NCLEX, the next gen NCLEX, is going to refer to signs and symptoms as cues. So this article is probably it's a new rendition of an old concept in neuronursing, but instead of using the word signs and symptoms, now we're using the word cues. Okay. How does the nurse interpret? How can a nurse use a patient cue? What's the importance of a patient cue to a nurse? What do they do?
When we should intervene on your patient.
Exactly. It gives you, when you see this cue, it lets you know whether or not you need to intervene, if this is a change, and whether or not you need to do something about that change. Why is it so important to deploy interventions based on cues?
Because acting at the wrong time can lead to a secondary injury.
Okay, so Ebony said y'all heard somebody else wanted to chime in. Also, did you have anything to add to that other person that was talking? Like I said, I can't see y'all.
I just said it helps save your patient.
Okay, yes, it can help it can definitely help save your patient. So basically, we do interventions all day long on people. Sometimes they're invasive, sometimes they're not. But for every intervention we do, what do we have to do? Not right after that. Sometimes you need to give a little bit of time. But what are we doing all day long?
Evaluate the patient.
You're evaluating the interventions that you do to determine whether they're working or whether they're not working. Whether the patient's getting better, whether the patient's maintaining status quo, or whether the patient is not responding to them. Okay. So there's a word in here in this article called entropy, and it's literally defined in there. Can anybody find in the article what entropy means? Keep on going down.
The degree of disorganization or potential for becoming organized.
Exactly. Okay, so it's either coming together or it's falling apart. All right, next one. Oh, you know what? Let me put this in slideshow thing so that y'all see better. Hold on, folks. Let me move it. Oh, wait, I gotta move it this way. Oh, here's my little fancy schmancy stuff I was using earlier. All right. Next slide. Why is my next slide not moving? There we go. What are physiological variables? Give me some examples because it is defined in your article.
It's oxygen saturation, ICP, cerebral perfusion pressure,
Okay.
perfusion pressure.
So those are what I refer to as the bells and the whistles. Those are the monitoring systems that we utilize as nurses to recognize cues that are going on for our patients. What's a situational variable? Well, what's a situation, folks? Don't everybody answer at the same time. Ashley Green's smiling.
Event of something that's occurring.
An event, exactly. So, situation. When I say the word situation, what does that bring to mind that nurses use all the time related to the word situation? It's an acronym. S is part of what?
SBAR.
SBAR. What's the situation? What's the background? What is it? SBA. What is that? Assessment findings. And what do you recommend? So basically, we are taking care of our patients. Patients a lot of times have these protocols, standing orders, especially patients in the intensive care units, because the intensive care units are historically specialized to whatever the patient's injury is or a health condition. There are neurological intensive care units. They have standard orders. You've already heard Ms. Garrettson talk about standard orders for a patient with an acute MI. Ms. Hopkins talked about standard orders for a patient on a vent. They're all the same. So we like standard orders because they give us autonomy to do a variety of things we need to do instead of consistently having to contact our physician. What would you like me to do next? What would you like me to do next? We as nurses, yes, they give us this laundry list of things we can do, but it's all about the critical thinking that a nurse does and the clinical judgment that a nurse uses based on all these cues to determine whether or not they're going to utilize part of those standing orders. Does that make sense to you guys? Okay, so we have our patient there, and we're in the neuro ICU or the trauma ICU or whatever, wherever our brain injury patient is placed. We do all these interventions because the patient's ICP is increased, their CPP is increased or decreased, their level of consciousness is faltering, their Glasgow coma scale is deteriorating. Okay, we know their O2 sat, all those other little cues, those physiological variables are out of whack. We have parameters for everything, right? As long as they stay within those parameters, we're good. But once they go out of those parameters, that's when we got to use our common sense and our clinical judgment based on the orders we got in front of us. What do I need to implement? And when we run out of orders, we've implemented every order known to man that we can on this patient and they're getting worse, that's when we utilize that SBAR to get help, because it is not enough to recognize that this patient has a problem. We as nurses must intervene. And when we get to the point where we have run out of interventions, we can't just stop there and say, well, we've done everything we can for this poor person. No, it doesn't work that way. That's when you have to recognize, you fill out your SBAR, because most nurses over time, experienced nurses working in whatever field of nursing you go into, we're going to know what these people need. We could write the orders ourselves. The medications themselves may vary, but the classifications of drugs aren't. The medications themselves vary based on physician preference. But we know we're going to have to give this classification of drug, this, and this based on our patient's condition. So when we run out of choices, we have to develop that SBAR. We got to get on the phone with our physician, and we've got to be able to get some more orders, because what we have orders for right now is not working. So I'm pretty sure I just answered this last question. What does the cue response, what do the cues tell the nurse, and what is the response theory provide to nurses? Basically, this article, and I highly encourage you to read it because it gives you a ton of information that to me, it was an easy read. It's not all filled with all kinds of mumbo jumbo. It lets you know, first of all, because they do talk about the experienced nurse versus the inexperienced or the newer nurse. So you guys are going to be graduating. Some of you may be going into intensive care units to work straight out of school. And there you go. I walked straight from school into the emergency room at Charity Hospital. However, I had been working there for a year and a half as a student nurse aide, tech, or whatever, and at least I knew where everything was. That was one. I was one up on that. But working somewhere as a tech only gives you the familiarity to the surroundings, and if you actually paid attention, it may have given you a little more information about how you're going to take care of your patient as a nurse. But experience is going to give you, nursing is on the job training, ladies and gentlemen, a lot of it. So don't be afraid that you're going to walk in feeling inadequate and everybody expects you to know everything. That's not the case. That's why you go through a training program. That's why you gain your experience. That's why you continue your education on your own to gain more information about whatever level or area of nursing you would like to go into. Okay, so that is basically what I am talking about. Does anybody have any questions so far related to this conversation we've been having about this article? If you do speak. Shaking your head. It's pretty straightforward. Okay, good. So the next thing that we're going to do, all right, I'm running actually ahead of time a little bit, so that's good. All right, so the next thing we're going to do is I like to do class activities. I like for you to have the knowledge in front of you already, and if you have your critical care book, this article, as well as the information you gain from listening to that recording and taking notes, you should be able to answer these questions. So what I'm going to do is I'm going to put you guys into breakout rooms. It worked well last week, and I'm keeping my fingers crossed that it's working again today. What we're going to do is each breakout group is going to have a question, a specific question. And I've got 8 questions, so I'm going to have 8 groups. And let me see up here, because I can't see it right now. Ms. Jean, can you tell me how many people, because when I'm sharing the screen, I can't see it. How many people are in this class?
I have no clue.
You can't see on there participants?
45.
45. Okay. All right. Thank you. So it's probably counting Ms. Jean and I, because Ms. Nickerson is teaching today. So the magic of Zoom, I tell them how many groups I want, and they randomly mix you guys up. So I'm going to let Zoom do its work, and you're going to get to meet people you may not have ever met before. So make a friend. I'm going to go into each breakout room. I have the capability of visiting y'all in each breakout room to give you your question. Samantha, you just took, are you able to see questions 1 through 3 totally on the screen? So actually that'll save me trouble. Can everybody, I'm going to show all 8 questions. Take a picture of all 8, take a picture of 1 through 3, and then I'll move it. Was everybody able to, I can't see y'all, but if not, I'm going to still visit every group just to make sure. Questions 4 through 6. Because you don't know what group you're going to be put into, but this way at least you have all the questions. And I also will post these questions under IC regulation so that you will have all of them to see to make your own notes. And then this is 7 through 8. And if you hear noise going on in the background, sorry y'all, that's my dog flailing around on the sofa. All right, so I'm gonna stop. Wait, hold on. Let's see. I want to get into my breakout rooms. Hold on, folks. I'm gonna end the show, and I might need to stop sharing my screen so I can do this. Wow, here we go. All right, so breakout rooms. Assign. All right, so I want to create 8 breakout rooms, and I'm going to assign them automatically. And so this is going to average 5 to 6 participants per group. Your job is to utilize the information that you have in front of you, preferably your book, your notes, that article. Answer the question. I'll tell you, most of it comes out that critical care book, FYI. So you're gonna, some person is gonna be the person to write this information down. Establish that amongst yourselves. One person is gonna be the presenter. What we're going to do is I am going to give you, it is 8:55 right now. I'm going to give you 15 minutes. It didn't take the group more than 15 minutes at all to answer this question, because you only got one question. Okay, so you're going to answer the question as a group. Some person is going to be the spokesperson. I'm going to turn off the break rooms, and it will show you a timer. This break room is going to close in, I think it's a 59-second countdown. It's automatically supposed to bring you back into the main group like where we are now. Each group presenter will discuss the answers related to these questions, okay? So y'all figure out how you're going to work this amongst your group. If you need me, I am here. You just have to send a chat, okay? All right, so does everybody understand your mission? Shake your head. Thank you. Okay, good. If you don't understand, you're in a group with 5 people. Somebody in the group ought to be able to figure it out, okay? All right, let's try this. If you get knocked out of your breakout group, sign back in to the link. I will see you've been kicked out, and I will put you back in your group. Okay? If you have any trouble, chat me. Okay? All right, folks, here we go. Let's see what happens. I'm going to open all rooms. Join your room. It should give you a message.
Morning, guys.
Hello.
All right, what questions do we have?
She didn't tell us yet.
This is a shit show. Oh my
Probably,
gosh.
probably
It said
question 6.
Yeah, it said breakout room 6, so it's probably 6.
What's
Alright.
the 6th question?
What should a nurse know about decompression craniotomy? Oh, that's easy.
Oh,
What should a nurse know about maintaining normothermia in a patient with a TBI? Okay.
I mean, I've seen that critical care book. I was looking at it last night. I found out what page it was on. It was like chapter 10. Still have that book?
Yeah, I have
Yeah.
the 7th edition.
Is it this book?
yeah.
Is that the book?
or this is, I don't know if that's.
Yeah, just a different edition.
finished.
That's must be.
So
That's
what
here.
what question we have?
6, I think.
It was the,
Craniotomy.
yeah. And then what should the nurse know about maintaining normal?
Just a normothermia.
Yeah, which
TBI.
I know that you have to keep them cool to keep the ICP down, or something like that.
Okay. So what page is this on?
I don't know if
Oh, I
I
have it. It's right on this page. I have it open too.
Page 256.
257 or
okay.
Another like 5th edition, I think. So this is probably gonna be different than you guys.
Yeah, hard to say. Yeah, 256.
the increased temperature can increase the ICP by increasing the cerebral metabolism
Yes.
and blood flow and swelling, and causes neurological deficits. So, says the nurse must be vigilant in identifying and treating hyperthermia and fever in the traumatic brain injury patient.
Do you want me to
Maintain,
type
maintain,
this out?
huh?
Do you want me to type this out?
I'll write it down. Or one of us can just read from the book.
Yeah, yes, I don't know. I just have to be on the page.
Who wants to talk?
Ew.
Anybody? What did you say, Megan?
Ew.
It's not my first choice.
You want to do it? Awesome.
Hey, okay.
I haven't, the whole craniectomy is kind of, do we need to know that kind of stuff? I mean, I guess so, but
Just opening to create decompression for the brain, right?
yeah, I just don't know if there's a nursing and what we're supposed to be looking out for.
They take out part of the skull, right?
Yes.
Or is that when they're putting like a
When there's
just-
too much pressure. Well,
No,
they
that's
can
true,
do the
but-
drain, but then sometimes they'll actually take out
Right.
pieces of the skull.
Yeah. Okay. So I guess the main thing is infection.
Yes. I
Watch
think
the
so.
type.
Okay. So that's kind of all that I got out of that is like monitor for infection. Did y'all see anything else that stood out on that part of
Would
it?
also monitor for infection with the thermoregulation too. That could be causing it. The high temp.
Right. Okay. And you don't want them to get too cold. Like it says you could wrap their arms and legs with towels.
I have this book that has like it goes through like bullet points.
Hey, group 6. Y'all understand? I know, I don't mean to scare y'all. Y'all do understand you're only answering question number 6?
Yes.
ma'am.
Thank you. I'm glad y'all comprehended that. Okay, I'm moving on to group 7. Goodbye, group 6.
All right, listen. There's with craniotomy, there are certain things that they have to avoid, like bending, lifting, straining, Valsalva maneuver. So there's like pre-operative and post-operative, right? Pre and post-op.
Yeah, like in this book too, it has like pre-op things. Like you have to
Do you have like the same stuff that I do?
like, stop all anticoagulants.
Like this stuff?
Cool. Okay. So then you can just list them.
Not the
Yeah,
same
my
thing
book
that.
doesn't have that.
Not the same thing, but I think similar.
I mean, yeah, they changed like 3 words in the entire book, and you have to pay $700. So they can make more money.
So y'all's books are bulleted to pre-op and post-op of that of
This is kind of like nursing care, like almost like a nursing diagnosis book. So like for temperature regulation, it's like monitor for signs of thermia, a temperature greater than 101, pallor, absence of perspiration, torso that is warm to the touch. As prescribed, obtain blood, urine, and sputum specimens for culture to rule out underlying infection. Be alert to signs of meningitis, fever, chills, nipple rigidity, Kernig sign, Brudinsky sign. Assess wounds for evidence of infection, including erythema, tenderness, and purulent drainage. If the patient has hyperthermia, remove excess clothing and administer tepid beds, hypothermic blanket, or ice bags to axilla or groin, but avoid inducing shivering.
Okay,
As prescribed,
quick.
administer antipyretics.
I just want to make
There's
sure that I have the full question because I thought I screenshot it, but I'm retarded. So it's just what should the nurse know about maintaining normothermia of the craniectomy patient, right? And that's it.
The patient with TBI.
So it's not just craniectomy. It's
I think it's two different questions.
Yeah, I think it's
Because
just
it's you have to keep the TBI patient overall. You have to provide cooling blankets to keep their temperatures down.
right.
Because if they have fever, that can increase ICP, make them worse.
okay. So the question is just about like their temperature,
Yeah.
about keeping them regulated, right?
Yeah, and like nursing interventions.
Right. Okay.
And what are you looking for, and what can you do?
All right. I just want to make sure. Sorry.
So pretty much, you want to keep them at like homeostatic level, right? Not too high or not too hot,
It's
not too cold.
flat or 30 degrees. 30 degrees is always a good. Can you lay them flat? Are we allowed to lay them flat?
No, I think it
No.
would have been
No, not
mess up the ICP. You want to keep them, I think, about 30 degrees. Is that right?
Uh-huh.
Right.
Yeah.
Okay.
So you keep them.
And you have to keep the head and the neck straight.
So when she says she wants to know about decompression craniectomy, does she want to know like indications for craniectomy are changing? The current indication is a continuing deterioration in neurological status despite treatment with signs of early herniation, such as a unilateral fixed pupil or a dilated pupil. One signs of late herniation, such as bilateral pupil changes and extensor posturing are present, the patient is less likely to be a good candidate for craniectomy. And then it goes through like post-op.
Yeah. So there is a complication such as infection, hydrocephalus, subdural fluid collection, seizure, and
I see that,
SAF leak.
So I guess we should read that part.
Yeah. Yeah.
So
Just
the
read the
indication-
post-operatively.
Right.
That paragraph, I think that's enough.
And the one above, indication.
Yeah. So that's all we need, I think.
I see exactly where you look.
Yeah. Okay.
Y'all see that? 256
Yes.
Yeah.
under depression craniectomy.
Yeah. Last two
Are you thinking
paragraphs.
under nursing diagnosis? This one?
It's page.
I'll have a different
No,
page.
yeah.
Oh, you're
It's
different book.
Yeah. So what are y'all looking at? I see decompression.
decompression craniectomy. It's like
Wait, I think
there's
I
a
can
long paragraph and then it's under that.
What?
let me take a picture and send it in the chat. If this works. Oh, might send to everyone. Let me see. I'm sending it to you, V. Sobolewski. Tell me if it's sent.
Yeah.
Did you get it? Tiffany, do you need it?
Yeah, will you send it to me?
Yes.
Download.
And then there's another
Where
part of
can you
it.
go to look at that you have it?
The chat.
Okay, nothing's come up.
Okay, it's sending
Okay,
to you.
got it.
All right, let me get the other part of it.
Do you download? Do you save it?
Yeah.
Wait, what?
Download,
asking-
save it on desktop.
So I have this textbook on my desktop. That's why I'm sending it like this. Okay, I sent the second part to y'all too. It was just to finish out that second paragraph that was cut off.
Just to throw it out there. This is not the way that I learn.
It's just to read to the group.
I understand, but this is like when everybody starts talking, it's gonna be such a chaos. You're like, okay, I'm just participating.
Who wants to talk in our group?
Well, since
I will
you
vote
have
for you,
the
Megan.
book, you can read.
Megan, woo!
Okay. that sounds good. And is it okay if I read? Is it
Yeah,
okay
that's
if
what
I?
I'm saying. You have all the stuff to read from.
Yeah.
So, I don't know. I mean, I would do it if I had the stuff to read from. I'm trying to look at the stuff you sent me, but I can't see all.
Is it okay if I read from this one for the thermoregulation, the things I read earlier about like the tepid baths, the ice bags to the groin?
I'll vote for you.
Yeah, I think,
Okay,
and
good. No problem.
I think, I mean, the normothermia is the most important part.
Right.
Because
So
that's
I have
the
all
question
these
asked.
all these interventions.
So, like, what do you need to know? You need to know that those brain injuries can cause, dysregulation of body temperature, and then what do you do for that?
Right.
Hey,
So
I think that's all it really is.
hey
and
Megan,
I'm just, yeah.
which page you have on the critical, this one, right?
Oh yeah, I have that. So mine might. What edition do you have?
I have a 6.
So I have 7, and I think it's in the trauma part of the book, and mine page is 383, but it might be different for yours. You can go in the back in the index.
Okay,
Probably
383. Let me try.
So with that regulation, thermal regulation, I just have just to control their ICP and metabolic needs of the brain. That's the purpose of give them acetaminophen and put them on a hypothermic blankets. That's pretty much it.
Yeah, I have it's like nine interventions listed here. So I'm just going to say ineffective thermoregulation related to trauma associated with the injury to or pressure on the hypothalamus can cause a fever in patients with a brain injury. And then read out what we can do for that.
Oh yeah, positioning, so it's 30-45 degrees. There it is. Facilitates
Yeah, I want to
venous
double
drainage.
check.
Yeah, I got it right here.
Okay. So 30 to 45 would be correct.
Yes.
Okay.
Do y'all have like the timer? Do y'all see a timer?
Oh,
What time-
no, I sure
No,
don't.
here.
Oh, here we go. It just popped up. Finish answering your
10
questions.
minutes. So I guess we're gonna break for
So we just come back at 9:30.
9:30.
It's a long break.
Yeah. Did she mean
Okay.
like a 10-minute break at 9:20?
I think
I
so.
don't
Yeah.
know. Yeah. Okay, so we can go to. So we answered our questions. We feel good.
Yeah.
I mean, it's just that basically the brain injury can cause dysregulation, and
And here's what we need to do.
pulling blankets, wrap their arms and legs, and position them off the blanket. All that list of things to do.
Wish you could throw some test questions. I'm like, okay, you're teaching all this stuff, but how you gonna word the questions? 76.5.
And there's also like cooling and sedating or paralyzing them to suppress the shivering also.
Yes, definitely.
Megan, what book is it that you have? The one that you're looking.
Manual of Critical Care Nursing, Nursing Interventions, and Collaborative Management. I just pulled this out today. I probably should have used it for test one.
Here's the saying, do you like it? You think it's worth getting?
I got it from someone and just pulled it out today. Because I thought this was the book she wanted, but I have that one on my desktop from that girl that emailed it over the summer.
Yeah, yeah.
So I have that, and then I found this earlier, and I was like, oh, well, let's look in here at traumatic brain injury. I mean, it's nice. It has like everything.
Hey, also, what's important to give them a stool softener.
So they don't vagal down.
Yeah, it will actually increase ICP.
Yeah.
Yeah.
Yeah, so we're giving them all this acetaminophen with codeine that constipates them. They don't poop and it goes. Miss Garrettson, I know. I had to do it.
But you had Miss Garrettson?
No, whenever she talks about, shocking people, I sing it. I'm clear, you clear. Everybody clear. It's a trip. Love her.
Well, platelets pump. This is funny.
Remember,
is there a temperature in here? Like, so I'm reading about what temperature we're, like a goal temperature. And
well, this says like for the cooling blankets, like, okay, the utilization of external cooling blanket requires continuous, accurate assessment of the patient's core or brain temperature. Usually the blanket is turned off when the patient's temperature is about 1 degree Celsius above the desired temperature. Okay, well, that didn't help. I'm sorry. Desired temperature. I guess it would just be normal.
Maintaining a brain temperature between 36 and 37.
I bet you that's not going to be on the test. I bet you my boots.
Well, I'm just saying to answer the question, to kind of
I know.
get an idea.
We just going with. It's exciting. Something. What's going to be on this test is going to be like a Glasgow comma.
Yeah, probably.
Oh,
yeah,
sure. That's
that
what. Yeah.
Which actually, this book does a really good job of explaining understanding. I mean, if you don't understand, it explains it really well in here.
But I'm a little confused about hyperventilation. Do we have to do or
It's
not?
supposed to decrease their CO. Well, we'll just wait and see what she says, but it's supposed to be getting rid of the CO2.
So if they're acidotic, huh?
Yeah, we'll just wait and kind of see. I don't want to say anything and
Yeah, when I read the book, I'm so confused. Should we use that or not? So.
Oh, let's keep it quiet.
Well, if you're hyperventilating, though, wouldn't that increase your metabolic demands?
Of course.
Yeah, so I don't, like I said, I don't know what, but the book says to hyperventilate them, or I don't know. I feel like it's a very fine line.
Well, the first they said if you hyperventilate them, they're gonna cause vasoconstriction, and so that's contraindicated. To increase the intracranial pressure. So then later on they said if the condition is become worse, you should use a hyperventilation. So I'm kind of confused.
Let's not do that.
Right, let's not. Yeah, let's let her see if she could. I'm sure maybe that's one of the questions.
Yeah.
We're gonna talk about temperature and
right
decompression.
right.
Okay.
So they have to be. There's certain criteria that they have to get the fluids off, and then I'll just recapping what we're gonna go over.
For the
We'll monitor
temperature.
them for stuff.
For
It's
the
a cool mug, by the way,
temperature.
Cindy.
Hmm?
It's a cool mug.
Okay, so for the temperature part, we have to keep the brain temperature between 36 and 37.
Yeah, I have that highlighted.
Yeah.
36 and 37.
Yeah, I'm reading. I'm highlighting what to say.
Yeah, and then to not they're gonna get cooling blankets. We can wrap their arms in the leg. I don't know if this is in your bullets, but we can wrap. This is what's in this book, the critical
Is this
care book.
in order to prevent shivering?
Yeah.
Yeah.
You can medicate them to prevent shivering.
The secret is to keep it short and sweet.
Yeah.
Let's not go into.
We don't want to go off and diarrhea them out.
I'm gonna read out what we would do to cool them down, and then after reading that, I'm gonna prevent shivering. What we would do, because if you cool them down too much, then they'll start shivering.
That will increase ICP.
Yeah. So. And
So we are
you got bullet points for the drainage system.
Drainage system. What that drainage system?
Or for the decompression.
Yeah, I have that.
In the poster. Yeah, they're gonna have little tubes sticking out, right?
Yeah.
If they need to.
I think the main thing on that is say just you're gonna monitor for infection on that, kind of thing.
Yeah.
I think that's the main thing. And then of course you're gonna continually monitor their GCS kind of stuff. Alright. Do y'all wanna take a break?
Yeah.
Again, how you feeling?
I'm okay.
Take a deep breath.
We're here for you.
Short and sweet.
Short and sweet. Right, short and sweet.
All right. So what time are we meeting? 9:30.
Okay.
And is it gonna go to this group or is it gonna go?
I don't know.
Probably the whole thing. She'll probably start with group 1.
I think you can just leave room and
Let's start with a Groupon. Right.
I might see y'all, I might see everybody else. We don't know.
See you on the other side.
Okay. Wait, do we leave this group? Leave the room?
We're gonna leave and meet somewhere in a different dimension.
Okay. Okay. Alright.
With unicorns and rainbows. Bye.
Alright, see you guys later.
Oh, leave the break room. Leave meeting. Interesting.
Yeah, I don't know how I just did that.
right, folks, I'm gonna close all these rooms. I've got 9:28. I'm gonna close them in about 1 minute, but I probably think y'all are done. Jessica, it wasn't that difficult to pull with these questions, huh? Yeah, no, I didn't think so. All right, let's see. It looks like a lot of people have already closed out their rooms anyway. All right, give me a minute. All right. Y'all have to leave your breakout rooms to get back to the main room. But I guess y'all figured that out. Okie dokie, we're almost back. Y'all hear me okay? Aye?
Yeah, we hear you.
Oh. I'm gonna give everybody about another minute to connect. And then, as I stated earlier, I know y'all took pictures of these questions, but I will post them to the main IC regulation tab on Canvas after I finish. I'll teach this obviously again to Team 2 this afternoon, so don't share it with them yet because I don't want them being overachievers and answering the questions and coming and not having anything to do for their little breakout session, okay? All right, I've got 9:30, so let's go ahead and get started. And if y'all want to record this, that's cool. Have at it. All right, so who is going to be our spokesperson for breakout room number 1 and question number 1?
It's me.
And all right, Ebony, thank you very much, ma'am. So the question was, this patient is admitted with a severe head injury. What are the goals of management for this patient? And list some immediate interventions that would likely be used to effectively manage this patient. What you got?
Okay, so we have obtaining thorough baseline assessment data, subjective and objective, depending on the degree of the injury. So that'll include vital signs and pain. We need to know GCS, whether or not this patient's going to get intubated, is intubated, whether or not they fall within the facility's protocol for being considered brain dead. We need to be preparing for any scheduled CTs, any follow-up CTs. If it hasn't been done, assuming, we know about iodine allergies and stuff. If they have any craniotomies or craniectomy procedures coming up that need to occur, we want to make sure we elevate the head of the bed to at least 30 degrees. Assuming there are no contraindications, we want SCDs in place and any other DVT prophylactic measures. We want to promote normothermia by way of either heating and or cooling blankets as necessary, implementing all physician orders, and specifically administering medications for pain, possibly sedatives, anti-epileptic drugs, watching for patient's response, whether or not it's worked. We need to be doing at least Q1 hour neural checks, assessing the pain, looking for any other cues. This patient needs to be NPO. We need to be decreasing stimuli, maintaining airway patency with airway and suction equipment at the bedside, implementing full spine precautions with a cervical collar in place, and getting a team of people together to perform those log rolls in Q2 hour turns, space and care.
All right. Save room for the other questions there, Eb. She's actually we're gonna get redundant, y'all, and y'all need redundancy because the more you hear these things, the more they'll either stimulate a question of clarification or hopefully stick this in your head. So, was there anything else, Ebony, you needed to add to that? You were good. That was a very comprehensive an accurate assessment of everything you need to do. And then we're going to hear about more. So thank you very much, Group 1. Strong work. All right. Who is the representative for breakout room number 2?
Me.
And me is, I don't see you. Oh, wait, you must be. Oh, all right, Gabby. So, question 2 is what are the signs and symptoms of seizures, priority interventions for a patient having a seizure, and what should the nurse know about positioning a patient who has a TBI, as well as, and I'm throwing this in because y'all already know it, but we're going to review it anyway, positions of patients who are actively seizing. So what you got, Gabby?
Okay, so signs and symptoms of a seizure would be like an aura, which is described like a sense of fear, anxiety, visual hallucinations, maybe a metallic taste in their mouth, dizziness, sensitivity to light and halos. So during the seizure, the best thing to do is, before to try to prevent a seizure, the best thing to do is reduce stimuli in the room to prevent risk of seizing. If the person is seizing, we should have the head of the bed flat, or if we're not in a hospital, help them to the ground. Safety is number 1 priority, so we want to prevent head injuries. So try to keep the patient's head away from anything that could cause injury. We need to pad the side rails, keep the side rails up. You can use blow-by oxygen during the seizure, but we would wait till after they are done seizing to put a face mask of oxygen on. If they're on the ground, try to lay them on their side. Nothing in their mouth, nothing on their face. We need to remove items from the bed. And after the seizure, we need to make sure we suction, use an oral airway if needed. Continue to monitor Glasgow Coma Scale, which should improve every hour. We need to take a glucose measurement after because they have, it's a hypermetabolic state during the seizure. If it's a febrile seizure, we would treat with antipyretics around the clock, and lorazepam can be used during an active seizure to help stop a seizure, and then valproic acid for preventing seizures long term. And then the traumatic brain injury positioning needs to be 30 to 45 degrees head of the bed. Anything lower or higher can increase intracranial pressure. And we need to not do anything that would increase intracranial pressure, like sucking through a straw, and the head and neck need to be straight, so not turning the head.
All right, so let me go back to and address the position. You said that when somebody's having a seizure, you want to lie them flat. So our patients are in beds. We're not seeing, I mean, if you see somebody seizing in the general public, sure, help them to the ground and lie them flat. Our patients are in beds. So the only problem with lying them flat while they're having a seizure, if they have a traumatic brain injury, is it's going to add insult to injury by increasing their ICP. So, as somebody who has seen multiple people seizing throughout my career, historically, where'd you get, I just need to know your resource for that, Gabby, so I can go back and read further on that. Was that your ICU book that you got that from, or what?
I maybe was just talking about laying them flat on the ground, but I do have written down where we said to do it at a 30 to 45 degree angle.
Okay, that's fine. I just wanted to clarify there because I don't want you guys thinking that if somebody's in their hospital bed, you're going to drop it flat, because that's not going to actually, that's going to add insult to injury. So when somebody's actively seizing, you guys have had seizures, you've had epilepsy in second semester, I believe, already. you're always going to have anybody that's at risk for seizures. What's going to be at the bedside, hanging on the wall, ready to go?
Suction.
Resuscitation equipment.
Suctioning. Okay, fine, great. Always suctioning. Airway, 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 right? Now, you also mentioned, so when somebody is actively seizing, I will tell you that unless they're in status epilepticus, by the time you go get your benzodiazepine, their seizure is over, just FYI, unless you've got it in your pocket. If they are in status, you're going to put them on a benzo drip. But these patients, brain injury patients, are historically not going to be put on a benzo drip. But rolling them to their side, when you roll in somebody, because obviously we want to make sure that if they, especially if they vomit, if they start to drool, because if you've ever seen anybody seize before, they will produce copious amounts of secretions. While they're actively seizing, obviously we want to keep the head of the bed up some to make sure that they don't aspirate, okay? You're not going to come at somebody during an active seizure with the yanker to try to suction them while they're seizing, because you'll probably do more damage and harm than you will to actively, suction them. The blow by oxygen is cool. Glad y'all pointed out the fact that you don't want to try to put anything on their face, because there are those that seize and they don't even move, and there are those that seize and they flail around all over the place. So airway is always your number one. Safety, if you have somebody that you suspect that they're going to have seizures, you want to put those seizure precautions in place so that if and when the seizure occurs, you'll be ready for it. You'll let the seizure occur, make sure they maintain their safety, and then deal with it afterwards. So airway, breathing, circulation, suction, turning them either side, or obviously if they got an injury on one side, you're not going to turn them onto the injured side, you would turn them to the opposite side. And the main reason we're turning them, y'all, is to prevent them from aspirating or vomiting on themselves. But remember, if these people have a C-collar on, you're going to have to do a log roll on them, because you can't just do that with the neck, or that defeats the whole purpose of having the C-collar, right? So you would have to get other people to at least help you to log roll them onto their side if they're seizing. Who knows how long a seizure is going to last? Hopefully it's not long, because it's scary as heck when you first see it the first time. After a while, you get used to it, but you always are concerned about them losing their airway and aspirating. At least that's my biggest fear when I see a patient seizing. And you made some very good points. Don't go at them with put anything in their mouth or anything like that. They will have, a true epileptic is going to probably have a postictal period afterwards where they're just kind of staring at you. They may be doing what we call sonorous breathing, where they almost sound like a horse. If you've ever seen that before, and they have their secretions coming out. So a yanker along the outside of it is appropriate. Wiping their face to get the drool off of them, that's always appropriate too. But safety is your big concern when you have somebody that's having seizures. Safety and aspiration are the number one things you're looking at. So that was, do y'all have any questions or concerns about what we talked about in question number 2?
I have a question.
Yes, ma'am.
So if we log roll them, we are gonna lay the bed pretty flat, just like temporarily.
If they're on a spine board, you got no choice. You got to roll the whole thing over. If they are, as long as because we're worried about cervical spine if they've got a C-collar on them. So you would ideally try to log them, but you don't want to put it flat. Yes, is it hard to log roll somebody who's sitting up? But I mean, we're talking about 30 degrees, y'all. We're not talking about like a 90. It's actually not hard to log roll somebody who is, and you're only talking about the cervical. So if you literally just try to roll the top portion of them, we're not worried about lower lumbar or thoracic. spinal cord injury, but then we're worried about cervical. So as long as this part and this part turn, I happen to be in my rolling chair, so this makes it easier. Turn like that. That will help you. Okay, but you're the only time you're going to turn them is if you're concerned about them aspirating, and if you get to them with the suctioning, you won't have to even worry about turning them. But to answer your question, no, you're not going to lay them at flat, because that's going to defeat your purpose. You can learn to log roll somebody if they are sitting up at about 30. It's not difficult it's hard to explain, but it's not difficult to do if you imagine it. Any other questions about that or anything else? All right, so who is the spokesperson for breakout room number 3?
I guess I'll do it.
Sure, Amanda, why not? All right, so this is our nutrition question. So this is, what should the nurse know about providing nutrition to a patient with a traumatic brain injury? When is it started? How is it implemented? And what safety concerns should be considered? So what did your group come up with?
They suggest that they receive a full caloric replacement by the 9th day of post-injury, and then start enteral feedings by 72 hours post-injury.
Okay.
And then you want to watch their glucose levels. Oh wait, I skipped a part. You want to start them at 25 milliliters an hour, and then increase it by 25 every 12 hours. But then you want to watch their sugar, that it's in between 110 to 180. You never want it over 200, because that can increase their intracranial pressure.
Let me address, Amanda, let me address those first 3 things first. So, full feeding within 9 days, enteral within 72, and then what did you say after that? Because I wanted to add something to that or address it.
Start at 25 mils an hour.
Okay, all right.
Increase
So
it.
that is a generalized thing. You're going to have tube feeding protocols at your hospital, and it's going to be a combination of your dietary department and your physicians that are actually going to collaborate together to establish. So I don't want you to think that 25 is a good number, but I don't want you to think that everywhere in the world it's going to start at 25 an hour. Just know that, and I'm not going to obviously ask you to start at 25, and I'm not going to waste a question on that. But just know that you're not going to start them at 100 milliliters an hour. Our patient that we've been taking care of for 3 weeks now has been at the same rate of 45 milliliters an hour for their tube feeding for over 3 weeks. Hasn't gone up, hasn't gone down. I don't know what they started at, but again, you don't expect big copious amounts of tube feedings to go on. And yes, this person's getting their AccuChecks. Yes, they're getting CBC, CMPs daily to monitor that glucose no matter what the feeding is. But again, I'm not so much worried about you not understanding a specific number. Yes, they're starting at 25 an hour. They're going to start them off at a low rate to make sure. Well, first of all, let me ask you all this. Before anybody starts with any kind of tube feeding, what kind of assessment do you as the nurse need to make?
Residuals.
No.
No. Before they eat, well, okay, so you can go.
You need to listen to bowel sounds. You need to make sure they're active.
Exactly. Yes. And that's something that because we're going to get orders for tube feedings all the time. But before you implement tube feeding, you need to make sure you've got active bowel sounds going on, because otherwise it's going to sit in their belly and it's going to regurgitate back up. Okay. So, but Ebony, you talked about residuals. your hospital has a protocol of when you're going to do residuals. Historically, it's every 4 hours, starting with the first shift, to see anything you pull out less than 100. Anything you pull out historically is going back in, because anything you aspirate from the gut has nutrients that the patient needs, so you're going to put it back in. But historically, if you pull more than 100, you're going to have an order for your protocol to shut it down for a while, and then you're going to let your doc know if they continue to have more than 100, because that means something's going on. Their gut's not working right, okay? So don't forget, before you go pushing medicines through a peg tube, you need to see how much is in that gut, because you don't want to fill out. And then you've got to make sure when you're making up your peg tube administration medications that you're not giving them a whole bunch of extra fluid, especially if they do have some residual, because if you give them too much fluid, they're gonna vomit. Okay. All right then. I'm sorry, Amanda. Go ahead. Continue. Did you have anything else to add to that?
I mean, I guess about the safety with enteral feedings, risk for aspiration.
What happens when you turn them? What happens when you have to turn them? What do you need to do? You need to put the pump on hold. Yes. Okay. Good. Okay. Anything else with that?
Risk for infection.
And why is that? Why do you think these people? Go ahead.
No, you can ask.
No, you tell me. Or anybody, why do you think they're at risk for infection with enteral feedings?
It's a bacteria environment, sugar, I don't know. Yeah.
There's within the tube feeding itself, like after a certain while back, it's a great environment for bacteria to grow. So that tube feeding, like the tubing itself and whatnot, needs to be changed out on a regular basis.
Actually, what is that regular basis, folks?
24 hours.
Every 24 hours, and the whole contraption gets DC'd. So that means that you got to also, as a nurse, you got to be a thinking nurse. You're mostly going to have their tube feed things, their bottles of whatever they're getting. You're going to have that in their room at their bedside. But if it's only going at 45 an hour, you're not going to fill that bag up the whole entire way, because A, you're going to be wasting and you're going to throw it out. And then B, the more stuff you got hanging in that bag, the more little critters can come in. It's supposed to be a closed system, and we're not supposed to be entertaining and adding a bunch of stuff to that other than what we're opening. So if you're only going at 45 an hour, 50 an hour, usually those bottles are 236, 40, something like that. So pour one in. It's going to take a couple of hours for that to go. And you should be monitoring those things that's hanging off of a patient, that's going into a patient. You should be monitoring that on a regular basis anyway. And then throw the whole contraption away. Put the date with your handy dandy Sharpie that every nurse should be carrying. Put the date on the bag, when you started, and the time. And then every 24 hours, you're also going to replace that suction kit with the cup. Don't put the date on the package, because the package gets thrown away. Put it on the cup and leave it at the bedside, and clean out your syringe and clean out your bottle after every usage to make sure that you don't have those little critters hanging out. Okay? Alrighty, so because again, you can just walk into a patient's room and probably identify about 20 different sources of potential infection, if you think about it, when you walk into a patient's room. So, all right, did you have anything else to add to that, Amanda?
No.
Anybody else? Okay, all right, any questions or concerns about that, nutrition and all?
Don't you also need to make sure that they never get bolus feedings, that it's only continuous? Because
that's not, so let me clarify that, Jessica. You are going to see bolus water, free water on people. What is your rationale of somebody with a traumatic brain injury not receiving what do you define as a bolus first?
Well, I mean a bolus feeding of like your like longevity or whatever they're getting. So you wouldn't give a bolus interval. So because that can increase metabolic rate, which will increase intracranial pressure.
So you're talking about,
I learned it when I was in school to be a dietitian. So we just don't give that.
Okay, all right. Well, you see, you're teaching me something. I'm trying to think whether or not I'm trying to remember if because I have given, and you're talking specifically to traumatic brain injuries? Because I know I've given free bolus waters.
Water's different. It's different.
And what volume constitutes a bolus?
So bolus would be 240 mils, like a full can.
Like a full can. Okay, all right. I have never heard that, but then again, I have not spoken to a dietitian specifically. I guess it could. I can conceivably see how it is, but honestly, I don't know if I've ever had a brain injury patient that's getting bolus versus continuous, because most of the time they need that continuous feeding rather than bolus. So you bring up a good point. I can't say yay or nay, but if you're telling me from a dietary standpoint, boluses are not good, I'm not going to argue with you. You can question, y'all. You get orders from doctors all day long, and guess what? Doctors are human and they make wrong decisions. You can question anything, but you could also say if you get something related to a dietary order, they're getting the information from the dietitian. So if you have a question related to that, I go straight up and call a dietitian to ask them, hey, I got an order for such and such dietary, blah, blah, blah. Is this correct? And can you just give me an idea of the rationale behind it? Just to make sure. I mean, that's what I would do, because dietitians are in and out all day. We see them all day long, in and out, dealing with our patients. So never be afraid to contact. We're doing patient care as a team. Dietary is a major part of any team. So please make sure that if you have any questions related to dietary, get on the horn with your dietitians. So thank you, Jessica, for bringing that up. You taught me something too. I'm always loving learning new things. So, okay. All right. Any other questions related to that? All right, then. Who is team number 4?
I am.
Oh, wait. Who is it? Who?
Tangie.
Tangie, you the spokesperson? Go ahead, girl. So, number 4, let me read to everybody. You're an experienced ICU nurse and you've got a patient with ICP monitoring, and you're going to construct a teaching plan related to a patient receiving ICP monitoring and CSF fluid drainage. I'm more interested in the ICP, but I definitely will hear about the CSF fluid drainage. So what you got, Tangie?
First of all, you want to teach the nurse to get a good baseline assessment.
Okay.
The baseline assessment is important. Teach her that she needs to do neural checks every hour. What else? Teach her that to monitor the MAP, the ICP, and the patient CPP, so that she can make sure that it stays within 70, above 70.
Which one? Because we're talking about 3 different things. What's the normal range for MAP?
The normal range for MAP is 70 above.
70 to 100. ICP, what we say,
70 100.
Right. What we say about ICP, what we want to keep the ICP at, range-wise?
Between
5 to 15.
70, I think.
No, ICP, folks.
5.
Jessica's raising her hand. What? 5 to 15.
15.
That is in your 5 to 15. Anything greater than 15, definitely do not go. We don't want anybody over 20. But if somebody is hovering greater than 15 and going between that 15 to 20, and they're going to do that when you back off on your intervention, let them go. But especially if they bump up over 20, back away from the patient. Stop doing whatever it was that you were agitating them and increasing their ICP. What is normal? The CPP for a patient with a brain injury should be between what and what? V, what you saying? Unmute yourself. I see ya. You look like you're giving me sign language.
50 to 70?
50 to 70.
50 to 70.
50 to 70. Why am I here? 50 to 70?
Yeah.
Okay, I can't. What is sticking out?
All right, map, whatever their map is minus ICP.
Okay.
I mean, yeah.
Yeah. All right. Cause
So that's like,
I'm going back.
Miss
to
Wiggins.
What?
I think you're talking about the CPP.
What did I say?
CPP.
You
Yeah.
said in a critical care book, it said something about 60 to 65 or something like that. But I thought
All right. Hold up. I'm looking, the algorithm I gave y'all, that big algorithm about patients with a traumatic brain injury. I'm opening that thing up right now to see.
It's 50 to 70 on it. I have it right here.
Okay, alrighty. I just wanted to make sure that I'm thinking of the right thing. 50 to 70. Okay, alrighty. Because these are narrow windows. We got to know what our parameters are to make sure that if we get above them or below them, we need to watch that, and we need to make sure that it doesn't stay that way. But it's going to go up when you agitate the patient. Every intervention you do to a patient with a brain injury is most likely going to agitate them because they're already in a heightened, agitated state from the get-go. We have to do, that's what that whole Q theory article was about, to let you know signs of the agitation, signs of all these things, so that you can know whether to back off on it. So, 50 to 70. I just wanted to make sure that I'm telling y'all the right thing and that y'all are saying the right things. So, okay, I'm sorry. Where were we? Tangi, what else did you guys have?
So also we're gonna monitor the patient for seizures, monitor the patient for CSF leakage. It will monitor to make sure it's not cloudy. Decrease the that the patient need decreased stimuli, and to use strict aseptic technique when doing care on the patient. Monitor for signs of meningitis, because the patient with ICP can have get meningitis also.
The main thing about that is anybody that's got ICP, an ICP monitoring device, the only way you're going to monitor ICP, and I think I told you guys that in my video, is that we are not going to drill a hole in their head. The neurosurgeon is going to get that pleasure of doing the crank and drilling. If you've never seen it, it's pretty wicked. Christy, the range for the test is what's on the algorithm, which is what, 50 to 70, right? For the CPP. Okay, so did that answer your question? I saw the chat question. We're good? Okay, so they're going to drill a hole in their head. They're going to insert the monitor, the probe, into usually the ventricle. They're gonna, or sometimes it's a bolt, whatever they have. All I know is they got a hole in their skull going into their brain tissue, which is any hole in anything is a portal of entry for infection. So we're not gonna, we're going to inspect around that, but we're not going to fiddle with the probe that's going into their head, but we're looking at what's draining out, and that's the cloudiness and all of that. CSF is supposed to be clear. It is not supposed to be cloudy. It is not supposed to be bloody. You have to monitor that. Okay. All right then. All right. So do y'all understand? I have a video. It's a 5-minute video. I'm not showing it now, but what I'm going to do is it's all about setting up the ICP drainage system. It's hard for me to verbalize what the system looks like, but a video is really good. You're not going to be tested on the setting up the whole thing. That we're not going to fool with that. But pay attention though, because we're going to talk about one thing you do need to know is where the level needs to be, and I think I talked about that in the video. When you talk about hemodynamics with Dr. Udo, we're going to talk about leveling things. Certain things have to be leveled in order to get the right reading. So I'm going to put that link to that video also on the IC regulation page so that you can watch it just to gain a better visual understanding of what's going on with these people when they have these types of monitoring systems, okay? Who is number 5? Group 5.
That's my group.
Alrighty, Jessica, y'all's question was, it's all about the drugs. How does mannitol affect ICP? Hypertonic saline affect ICP? What are the pros and cons of using each drug? What medications are used to sedate a patient with a TBI, and what medicines are used to manage pain in patients with a TBI? So what'd y'all come up with?
So mannitol and hypertonic saline are both used to decrease the osmotic pressure. Mannitol is an osmotic diuretic, and hypertonic saline also will pull, it's a hypertonic solution. So it's usually about 2, 3, 5, 7.5%. And the saline is usually run at rates from 30 to 150 milliliters per hour. With that, you do have to monitor the serum sodium levels, at least Q6, and because they have a risk of running, becoming hyponatremic. Also assess the patient's overall fluid volume status, including their weight, central venous pressure, eyes, nose, because they could become, their volume status could be compromised. And then serum osmolarity should be measured at least every 12 hours and maintained at less than 320 milliosmoles per liter. Mannitol is not as quick as the hypertonic saline, and then it's usually given in doses of 0.25 to 1 gram per kg of body weight. So, and it's usually not, it's scheduled every 2 hours. And then as far as sedation goes, the toxic side effects, of course, is low sodium. The sedation is Precedex, and now I'm drawing a blank. Propofol, and those are also used for pain relief in addition to morphine. So morphine is also used.
Wait, just let me interject for a second. Sedation is not to be used in lieu of pain medication. Yes, sedation will sedate you, but remember, it does not help. It'll knock you out, but that doesn't mean that the patient is not still feeling pain. So please understand that you're going to be doing a combination of sedation as well as pain treatment. So you talked about morphine, and what's the other one that's used also for pain that they said in the book? 2 things. Morphine and what?
I just saw morphine.
Did they not list fentanyl in there?
Oh, fentanyl. Sorry.
Yeah. Okay.
No,
all right.
Versed.
Versed is not a narcotic. What is Versed?
But sedative, right? I mean,
What's the classification?
The paralytic.
That's a good question. That's a paralytic. Mm-hmm.
Wait, what'd you say was a paralytic?
Anxiolytic, right?
What did you say? Wait, what did you say? Versed?
Versed.
Versed is a what? What's the classification to Versed? It's a PAM.
It's an anxiolytic.
Benzodiazepine.
It's a benzodiazepine. Versed, Ativan. They're benzodiazepines. A paralytic is something else. Rocuronium is a paralytic, and
Nimbex is a paralytic.
yeah, they've got a list of all the different paralytics. Benzodiazepines are given. Narcotics are given. Sedatives are given. Be careful with propofol. Propofol is a wonderful drug. It's quick acting. It wears off. It's got a very short half-life. So if you need to give the patient a sedation vacation, propofol is a good one to use because as soon as you turn it off, it takes minutes and they're awake again. But we really don't want to wake up a patient with an increased, we'll get to that part when we do want to wake them up, but you just got to, also another thing that you have to remember is when you're hanging propofol, it comes in a bottle. I think it's 100 milliliters to the bottle. It's white liquid in a glass bottle. I don't know if y'all ever saw it before, but you never want to run out of it. You always want to have your other bottle ready to go because God forbid you got to get it from pharmacy. If it's not your Pyxis or your whatever your source is, you always want to have it ready to go. If it's a continuous infusion of anything, there should never be periods where you're like, oh, it's done. Let me turn the pump off, call pharmacy and get another one. No, a thinking nurse is on the phone to pharmacy, having their next bag ready to go. So as soon as that other bag is done, you're popping it off, you're putting a new one on, so that a continuous infusion does not mean let's break for about 15 minutes to get another bag from pharmacy. A continuous infusion is continuous, folks. So be a thinking nurse who thinks ahead and plans accordingly, because it's nothing pretty to have your sedated patient come out of their sedation because your propofol is gone and they're flailing around all over the bed and their ICP is through the roof. And it's your fault because you didn't plan ahead and get your drugs on time. Okay? All right, sorry. What else you got?
I forgot to mention that any drugs that come in a dextrose solution, you have to call pharmacy and get them switched to a saline solution because dextrose increases ICP.
You have to monitor. In fact, a lot of times people don't think about that, but patients who are diabetics, and I know I'm getting off topic for a second, but think about this. You got a patient that's they're diabetic, but they got an infection, and they're getting copious amounts of antibiotics that are filled with dextrose, and you're wondering why their Accu-Checks are so high. We can switch a lot of those medications from dextrose to saline if we let our doctors know that, hey, the 5 antibiotics that this patient is getting is mixed in dextrose. They're continuously hyperglycemic. Would you like to put an order in to maybe switch them to a saline if they can tolerate it? That's just something that you can think of, because we don't necessarily get the choices. Pharmacy usually tells us what we're going to mix it in, but that doesn't mean we can't be the thinking nurse that knows that certain things that can be mixed in dextrose can also be mixed in saline, and we have to think about that. It's something that you'll start learning about and thinking about as you become more experienced as a nurse, amongst the 8,000 other things you need to think about as a nurse during the day. So thank you for bringing that up. All right, what else? Anything else to add to that? We're good with that? Did anybody have any questions? Hypertonic saline, You must be very careful with that, okay? Patients who are getting osmotic diuretics, what are you going to be monitoring on them? What does an osmotic diuretic do?
It pulls the fluid back into the intravascular space.
Okay, and then what is it supposed to make them do? What do diuretics make people do?
Diurese.
Diurese, that's right. And how can we monitor the effectiveness of diuresing? Urine output. Okay, you need to look at urine output. Thank you. These people will be on hourly INOs, hourly vitals, hourly neurochecks, hourly a lot of things. Okay, and Nicole, you will be taking care of them. All righty, so who's got number 6? The decompression craniotomy person.
That's me.
Megan. All right, thank you, Megan. So you're going to tell us about what a decompression craniotomy is and what should the nurse know about maintaining normothermia.
So for decompression craniectomy post-op, the patient is critically ill and usually has an ICP monitoring device in place. So we're going to keep an eye on that. I think the big thing for that is to not turn the patient's head on that side because the cranial contents will move inward, increasing the ICP. And we're also going to watch for complications such as infection, hydrocephalus, subdural fluid collection, seizures, and a CSF leak.
Okay. What about normothermia?
So for that, an increased temp can further increase ICP. So we want to maintain a temp of 96.8 to 98.6. Antipyretics and physical means of cooling are the biggest interventions here. So some of those we monitor for hyperthermia, temperature greater than 101, pallor, absence of perspiration, a torso that is warm to touch. As prescribed, maybe obtain blood, urine, sputum specimens for culture to rule out underlying infection. Be alert to signs of meningitis such as fever, chills, nupal rigidity. Assess wounds for evidence of infection. If the patient has hypothermia, remove excess clothing and administer tepid baths, hypothermic blanket, or ice bags to axilla or groin, but avoid inducing shivering.
Right, because that increases your metabolic demands too.
Right, and some things to do to avoid the shivering include use higher temperature on the cooling blanket. You can go up as high as 75 degrees. Wrap the patient's arms and legs in cloth towels and position them so they are off the blanket. Place a bath blanket between the patient and the hypothermia blanket to prevent burning the patient's skin. Medicate the patient. That's it.
All right, that was quite comprehensive. Thank you for that. 7, who's group 7, which is the importance of facilitating communication.
That'll be me.
All right, Mark, what you got?
So when it comes to communication, it's providing clear and clear. It's communicating clearly with the patient's family, as well as making the information comprehensible. We're kind of dealing with a lot of things that are brand new to people, whether it be equipment, diagnoses, drugs, or just the management of care. So it's making sure that the family knows what we're doing, why we're doing it, and what to expect. Not to be super optimistic nor pessimistic, but to give them a clear understanding as to what can happen and the full range of possibilities. So it's like a holistic approach. You're not just dealing with the patient, but the patient's family, and giving them all of the information, not just some of it. And then not just keeping that as far as the initial communication goes with the family on initial admit, but then continuously, because these patients are probably going to be in the ICU for an extended period of time. Mm-hmm. So it's going to be making sure that style of communication continues not amongst the day shift, the night shift, and throughout the stay of that patient within the ICU.
Okay.
And then when it comes to coma stimulation, we want to make sure that the patient is steady for at least 72 hours before before initiating coma stimulation, and it's basically trying to attempt to arouse some sort of patient awareness. So yes, we're keeping the room quiet and low stimuli, but that stimulation is simple things, talking to the patient, simple tactile, holding a hand, brushing the hair, that sort of thing. And then within the critical care text, it was saying that there's no evidence, either positive or negative, as well when it comes to multi-stimuli. So like holding a hand and talking at the same time, you can do that, or one at a time. There's no evidence to say whether or not single stimuli or multi-stimuli is better than the other.
Okay, all right, then, yeah, that's true, because a lot of this stuff is foreign to the layperson. I mean, I'm a skilled clinician, and some things that they have that people are attached to, I have to ask, and they try to explain to me, and I'm like, okay. So keep it simple, understandable, but don't only give them half the story. Give them the full story, because it's they need to be, the family needs to be aware of the entire picture, the whole holistic thing going on with the patient. Okay. All right. And the last thing we have is the who's group number 8? Don't speak up at the same time. Do we have a group number? I know we had a group number 8.
I'll speak on behalf of group number 8.
Thank you.
So the question was about the complications as it relates to traumatic brain injury.
Yeah.
Some things are pneumonia, aspiration pneumonia, ARDS, deep vein thrombosis, diabetes insipidus, sodium imbalances, and DVT. Well, I say DVTs. Oh, and ARDS. Those are all complications of traumatic brain injury.
All right, you've had everything, but you've learned about everything but the DI, and Mijan is going to teach you about the DI, and that's a side effect. And Mijan, is that test 2 or test 3? I don't remember.
3.
It's test
3.
It's test 3, and I'll lecture on it tomorrow.
Well, there you have it, doggone it. So it'll put the picture together, and I'm not going to give you any questions about DI because I don't want to steal Miss Jean's thunder. So, do you guys have any questions related to this? If you do, and you don't want to ask them now, by all means, utilize the discussion board. I will put these questions on the thing after this afternoon session, and then I will record this afternoon session. If you did not record it now, then I will be able to have that conversation. I'm hoping they have the same wonderful answers that you have, but you'll have these questions on your own after 2:30 this afternoon for you to answer and utilize them along with the other information I gave you related to this topic. So please ask me any questions you need to. Now, if you don't want to ask a question on the discussion, there's no stupid question, y'all. Honest to God.
What are the answers?
Except for Victoria Wagasback's question. Well, she just asked me, but I'm going to let her slide because I'm pretty sure in her lifetime she probably had a traumatic brain injury, so we're going to use her as the poster child. Where is she? She can run, but she can't hide. Okay. All right, folks. Y'all have a wonderful day. It's beautiful outside, so go study outside if you want to. And ask me any questions you need, okay?